I'm Dr. X, and beside me is Dr. Matthew. And today we're walking you through the exact clinical map you'll lean on at 3 a.m. when a patient rolls in with acute abdominal pain. This is the workflow that separates chaos from clarity, and if you master it, you will not freeze during your shift.
Let's start at the top. Patient with acute abdominal pain. Acute abdominal pain is never just pain. It's a potential threat. Your job is to decide whether this is a medical abdomen, a surgical abdomen, or a dying abdomen. Everything downstream follows this logic.
First node. Initial steps. History. History in acute pain is pattern recognition. Ask about onset, location, character, radiation, and progression. Here's the classic rule you must engrave into your reflexes. Pain before vomiting suggests a surgical process. Vomiting before pain leans toward medical. Ask about fever, urinary symptoms, bowel habits, anticoagulants, immunosuppression, and recent surgery. Every one of these shapes your differential.
Next, physical examination. Your hands tell the story here. Guarding, rigidity, rebound, these are signs of peritoneal irritation. Don't skip lung bases, CVA tenderness, hernia checks, testicular exam when indicated, and rectal exam when it matters. And remember this anchor. Pain out of proportion to exam should make you think mesenteric ischemia or AAA.
Now we hit the biggest fork in the entire map, hemodynamic stability. If the patient is stable, you have time to investigate. If the patient is unstable, your entire thinking changes. Stability dictates the path.
Let's follow the unstable branch first. Unstable right pointing arrow immediate interventions. 2 large bore IVs, oxygen, fluids, crossmatch, bedside glucose. If bleeding is suspected, activate the massive transfusion protocol. And ultrasound becomes your immediate guide. Fast exam for free fluid, check the aorta for aneurysm. You're not doing a full diagnostic workup, you're stabilizing a patient who might crash.
If instability persists or you find concerning findings on ultrasound, get surgery involved early. When a patient is unstable, you don't chase CT scans. You protect the patient.
Now let's go to the stable patient branch. Stable patients get a structured, evidence-based evaluation. First, bedside tests, urinalysis, pregnancy test, and point-of-care glucose. These quickly rule out DKA, urinary sources, and pregnancy-related emergencies.
Next node, comorbidities and special risks. Diabetics can hide peritonitis. The elderly hide everything. Immunosuppressed patients often look deceptively stable until catastrophe hits. Post-operative patients, very high risk. Think obstruction, leak, abscess, or ileus.
Diagnostic studies, labs, CBC for infection or bleeding. CMP for electrolytes and hepatobiliary clues. Lipase for pancreatitis. Lactate is one of your highest yield numbers. Elevated lactate should trigger concern for ischemia or shock. And beta-HCG is mandatory in all reproductive age females. Never skip it.
Next, imaging. CT abdomen, pelvis with IV contrast is the workhorse for most stable patients. Ultrasound is first line for RUQ pain, gallbladder disease, pelvic pathology, and AAA screening. Non-contrast CT is your go-to for kidney stones. MRI enters the game mainly for pregnancy when ultrasound isn't enough.
Now we reach the crucial analysis node, decision after studies. At this point, you sort the situation into 2 big categories. Surgical causes: perforation, appendicitis, obstruction, ischemia, complicated diverticulitis, peritonitis. Medical causes: DKA, pancreatitis, gastroenteritis, hepatitis, renal colic, mesenteric venous thrombosis.
And this is the golden rule here. If the patient is unstable, peritoneal, or progressively worsening, call surgery early, not late. A perfect CT does not save a deteriorating patient. Early action does.
Final node: observation or discharge. If the workup is reassuring, symptoms improve, and the patient tolerates oral intake, you can observe briefly or discharge, but with strict return precautions: worsening pain, fever, vomiting, inability to hydrate, or bleeding.
Because while benign pain stays benign, evolving pathology can turn dangerous quickly. Your safety net is the clarity of your instructions.
And that's the full acute abdominal pain map: clean, structured, and ready for real clinical pressure. When shift chaos hits, this algorithm becomes your backbone.
And next, we're going straight into dizziness, a differential so tricky that even seniors hesitate. You'll want that one in your toolkit even more than this.
Stay close. Med Short X continues.